All right, another case about wide complex tachycardia, which I think is pretty interesting. And again, it's to highlight the things I was talking about in the other cases about how we should approach and treat this wide complex tachycardia. Again, I don't claim to be an expert. I'm not saying you should listen to me or believe what I say. I'm just telling you this is the way I think and this is the way I practice based on the stuff I've read and like the cases I've had. All right, the last video, this was the riddle. The answer is nothing. The rich want nothing, the poor have nothing. Nothing is greater than God, and if you eat nothing, you'll die. Same thing for this video. Here's a riddle to let percolate in your mind. What happens once in a minute, twice in a moment, but never in 1,000 years? Again, if you want to, use this as an exercise. Let this just rumble around in your brain for a couple days until you figure it out. All right, this case is a case I had with Dr. Max Ritchie. He's one of the second-year UTMC residents. This was earlier this year. Again, you might have seen this case in public, but I'm putting it on here to help highlight points of what I'm talking about. Look at his little baby face. He's got a sick beard now, but that's Dr. Ritchie. All right, here's the history. Remember, the value of any EKG depends on your pretest probability, and we get our pretest probability from the history. 70-year-old female with a medical history that includes mechanical mitral valve, on warfarin, coronary artery disease, COPD, fibromyalgia, hypertension, that's presenting for blood in the urine, blood in the stool, found to have blank, okay? Patient noticed blood in the toilet paper when she wiped after she had a bowel movement, and has been urinating blood for the past couple of days, so she called EMS. When EMS arrived, they attempted EKG and were concerned for STEMI, so they brought the patient to our hospital. En route, the patient was provided a dose of labetalol, nitroglycerin, and aspirin. Currently is complaining of pain all over, states it's her fibromyalgia pain, denies any chest pain or palpitations, does endorse lightheadedness for the past couple of days, both at rest with activity. Also has associated shortness of breath, both at rest and activity. No cough, no fevers at home. Denies any edema. Currently denies the symptoms. Denies dysuria or frequency. Okay, so a couple things from the history to note to help us figure out what to think about the EKG. Is her history. So she's got a mechanical valve and she has a history of coronary artery disease. Okay, she is complaining of symptoms. It's kind of difficult to nail down. Yes, she is complaining of pain and shortness of breath. None currently. She does state her symptoms are worse with exertion prior to arrival. So those are all of our pre-test evaluations. Here is the EMS EKG. And this is the EKG that they had that was concerning for STEMI. Okay, same thing. Pause, look over it, write down what you think, and again, give me your interpretation. And remember, interpretation means the action of explaining the meaning of something. Okay, here's what I see on this EKG. Again, it's difficult to ascertain exactly what's going on because it's so irregular and so just jacked up. I mean, there's no other word for it. Let's start with the rhythm. And again, this thing at the bottom is called the rhythm strip for a reason. Just read it from left to right. And the rhythm strip is often either lead 2 or V2, because those are the leads to best see P waves. So when we start from the left to right, we see P, QRS, P, QRS. Again, 1 P for every QRS. And then we get into this area where there is a wide complex rhythm with no visible P waves. And then we go back into a sinus rhythm after this. So this is definitely a non-sinus rhythm, right? Because to have a sinus rhythm, you need 1 P for every QRS. We have QRSs without P, so this is definitely not a sinus rhythm. Now, to determine the axis, that's difficult, okay? Because when we look through these leads, we have this irregular QRS complex that bounces back and forth when the rhythm changes. So if we look closely, remember all these beats vertically are the same. We can find one sinus beat in lead 1 that is upright. If we go down here to lead AVF, we see another sinus beat that is upright. So I'd say the underlying native axis when you have a sinus rhythm is normal. And again, these beats are the same. So when we look here, we have a downward access in lead 1 when we have this extremely wide complex, and a downward QRS and AVF when we have this wide complex. So when we're in this other rhythm, it's an indeterminate access. So that's pretty interesting and can also help us figure out what's going on. Like when there is a normal sinus beat that conducts through, the axis is normal, but when we're in this ectopic unknown rhythm, the axis is indeterminate. Okay. I circled a bunch of things. Okay, so let's go through here. When we look through here at these precordial leads, again, while we're having this arrhythmia, we notice some morphology abnormalities. Number one, it's mostly upright in the precordial leads. It has this right bundle branch block appearance. But if you note, number one, the appearance is not consistent. Like the morphology of this QRS is different than this one and is different than this one. And we don't see the classic small r, large R prime, which we would expect to see in a right bundle. Same thing down here. I mean, this is just so cattywampus, we can't see what's going on. And we see the abnormal appearance of the right bundle, like this is the R and this is the R prime. Like here, the R is almost twice as big as the R prime. It should be the other way around. And if you look, I circled this right here, which is this slurring or this notching of the S wave in the precordial leads. Other things to note is, again, over here in V6, we can see the two different complexes presenting themselves. We have, number one, the normal complex when we have a P wave, where the QRS is upright in lead 6. When we have this abnormal conduction, we have a large S wave and a small R wave, or actually no R wave in lead V6. The main thing here, and the thing that, EMS was concerned about for the infarct, is this amount of disproportionality, okay? So again, if we look closely, and we remember, these beats are all the same, when we have this underlying native beat where the beat does go through, we can notice that it has a complete left bundle branch block appearance, okay? It is wider than 120 and it's down the precordial leads. So we have this complete left bundle branch block appearance when the native beat goes through. For this abnormal conduction, we have this atypical right bundle branch block appearance. And if you note, if we map the J point on these leads, we can say there's J point elevation from the PR segment. Again, it's difficult to assess where the J point is sometimes, so find a rhythm where you can clearly see where the J point is. Down here in this lead, we see the QRS starts here, definitively ends there, so let's follow up. There's the J point. In this lead, there's about 4 to 5 millimeters of J point elevation from the PR segment. And in this lead, again, we can see there's about 4 to 5 millimeters of ST elevation compared to the PR segment. If we look at these leads as well, we can also see there's an abnormal appearance of the P wave in V1 and V2, which is a biphasic P wave, which is suggestive of left atrial enlargement. Okay, so here's my overall interpretation. This EKG is consistent with non-sustained monomorphic ventricular tachycardia. Okay, when we do have this abnormal conduction, you can see it's monomorphic in appearance. All the QRSs are pointing the same way and look the same way. And again, there's many things that help you differentiate out these things. The things on here which argue towards ventricular tachycardia is, number one, the indeterminate access. Number two, the abnormal appearance of the right bundle in the precordial leads. Number three, Joseph's sign in the precordial leads. Number four, an S wave larger than an R wave in these lateral leads. Number five is there is a large Brugada interval here, which is the time frame from the beginning of the QRS to the peak of the QRS in the precordial leads. And again, all of those things are fancy and make you sound smart, but they're not definitive. Remember, when you see a wide complex tachycardia, the first question is, are they stable or unstable? If they're unstable, you do cardioversion. If they're stable, you reach for medications. Which medication you choose, again, depends on your pretest probability. The other thing here on here, again, which I think is more valuable than all this fancy electrical stuff, is the pretest probability, right? Like, look, this patient is 70 years old and has a history of a STEMI or an infarct before, right? Like if you're, again, the value of any EKG depends on your pretest probability. She probably has a scar, and we know she has structural heart disease from this mitral valve. It's most likely monomorphic ventricular tachycardia just from her pretest probability. These other fancy electrical things on here, help confirm my suspicions, but you really don't need these, right? All you need is, number one, the pretest probability, and number two is, are they stable or unstable? And also, if you note, in the history, she got a dose of labetalol from EMS en route. So this is the EMS EKG. Here's the EKG when we saw her. Again, pause, write down your findings, and think about what your interpretation is. Excuse me. So here's what I see. Number one, we're back to normal sinus now. Okay, now we have this beautiful rhythm strip where there's 1P for every QRS, so there's no more arrhythmias. We're back in sinus. Nice job, EMS. Okay. Number two, the axis I would say is normal. Number three, for the intervals, we do have a widening of the QRS, and we have a downward appearance of the QRS in the precordial leads consistent with a complete left bundle branch block appearance. I don't see any definitive prolongation of the QTC. For the ST waves, we do have diffuse non-specific ST wave abnormalities. I do see J-point deviation in multiple leads, but in my interpretation, this J-point deviation is to be expected as it is an appropriate discordance in the setting of a left bundle branch block. Okay. Remember Scarbosa's criteria, and those are twofold. It's either any concordance where the J-point is in the same direction of the isoelectric point with the QRS, or any inappropriate discordance, that's where the J-point is in the opposite direction of the isoelectric point from the QRS. This is always confusing, so let me be clear here. In a complete left bundle branch block or a ventricular paced rhythm, you expect to see some degree of discordance. Let me say that again. In a left bundle branch block or ventricular paced rhythm, you expect to see some J-point deviation from the PR segment in this condition. Okay, that's normal up to a point. The old rules was 5 millimeters. The more accurate rules is Steve Smith's rule, which is 1/4 amplitude of the QRS. And you can see that highlighted in multiple leads here. Okay, let's look up at lead 1. Again, for these blocks, always be clear where your J-point is. We can clearly see here in V3, this is where the QRS starts, this is where it ends. We follow the J-point up, and yes, there is J-point elevation from the PR segment in V1. I'd say it's about 5 to 6 millimeters, okay? Come down here to V2, same thing, about 3 to 4 millimeters of J-point elevation. Here, maybe 1. We would come out here to V4, 5, and V6. There is some J-point depression to the PR segment. Again, here's where the QRS clearly ends. We can see the J-point is depressed from the PR segment here. Same thing in V5, same thing in V6. Same issues over here in lead 1, lead 2. The J-point is depressed to the PR segment, but that's opposite of the QRS. That's appropriate discordance. Same thing in lead 2. Here in lead 3, it's iffy. It's tough to say. This is borderline concordance. It's more up in 3. Could that be concordance? Like we're splitting hairs there, but that's just one lead. And same thing here, we have appropriate discordance. And again, this is a good example of why we should be using the Steve Smith proportionality type rule, which is 1/4 and not 5 millimeters. Because yes, this is approaching 5 millimeters, but look at it in proportion to the QRS. Like, look how huge this QRS is. That's like what, 5, 10, 15, 20, like 22 to 25 boxes. Like, that's huge. 5 millimeters, that's less than 1/4. That's why you should be using the proportionality. Now, the other question is, well, why did this rhythm improve? If you remember, they gave labetalol, right? Which is the medication that has the best chance of resolving non-sustained monomorphic ventricular tachycardia. And again, the patient was admitted to the hospital. She did well. Here's her echo. Asymmetric increased wall thickness. Systolic function is hyperdynamic with ejection fraction of 7%. There's moderate to severe regurgitation. Mechanical prosthetic valve in proportion size unknown. There's mild to moderate, or trace to moderate regurgitation of the aortic valve. And again, this is to highlight, like we talked about from this pathway. And again, this pathway is not set in stone. This is just how I like to remember it in my mind. And my recommendations is everyone learns differently. While you're in residency in medical school, you have to learn how you learn. And the best teacher you should have throughout your career is yourself. Like, this is how I teach myself. If you like it, great. If not, then don't use it. And again, so we fell into this monomorphic ventricular tachycardia. Again, the most common cause is structural heart disease. And the two subtypes of monomorphic are sustained and non-sustained, and the differentiating fact is 30 seconds. Our patient had less than 30 seconds. That was non-sustained monomorphic ventricular tachycardia. And the most appropriate medication choice is beta blockers, which EMS gave. And again, recall the first question when you're dealing with this wide complex tachycardia is stable or unstable. So those are the teaching points I have for this week. Short of the story is this was a case of non-sustained monomorphic ventricular tachycardia, which was from structural heart disease. It responded to labetalol, which is a good medication to use for non-sustained monomorphic ventricular tachycardia. The other teaching point is there's many fancy nerd EKG things you can use to help you differentiate VTAC from other abnormalities, but it's not 100%, and the main thing depends on your pretest probability. If you have someone who's elderly and has a history of coronary heart disease, it's probably going to be some type of monomorphic ventricular tachycardia. That's all I have for this case. I hope you enjoyed. Questions, ask me in person. Peace out.